Hi, everyone. So the C-Spine talk that we did on Wednesday wasn't well recorded. I'm trying something new where apparently I can appear on screen and this can be a background as well. So I hope it looks okay. Just that there's some things that I just need to explain to you guys as well. So we're just going to go through an introduction to C-Spine injuries. There's some things that I need to demonstrate as well. So that's why I'm just keeping myself on the screen. It's a bit strange because I'm looking at the slides and not looking at the camera. So if it looks like I'm looking down all the time, I'm also admiring how little I've shaved this last week. And yeah, it looks horrible. Okay, but anyway, hopefully you guys enjoy it. So the thing is with C-spine injuries, especially in the emergency department, you have this issue where you can learn it from a radiology point of view, or you can learn it from an orthopedics point of view. But in the emergency department, you have this issue where we need to work fast and we need to work accurately, which are two things that don't often go well together. Generally, if you work accurately, it takes you time. And if you work fast, you tend to be inaccurate. So we need to develop ways to look at these types of x-rays that allows us to be accurately and quick. And the way that we do that is actually by looking at these three lines that I'm now going to demonstrate to you. Now, when you learn it in radiology and orthopedics, they actually talk about 5 lines, but we talk about 3. Now, the 3 that have to the 3 that guide us are these. These are the anterior lines, all right, which forms along the anterior vertebral body. The middle line, which is the back of the vertebral body, and then the third line, which is the back of the spinous process. So these are the 3 that guide us. Now, in order to have an adequate C-spine X-ray, there's a few things that you need to know. You have to be able to see these particular vertebrae. You have to be able to see C1, C2, C3, C4, C5, C6, C7, and the top of T1. That's how you say it's an adequate X-ray. Now, if it's an inadequate X-ray, you may, for example, only see up to C6 or C5, and that's when you ask for a swimmer's view. So a swimmer's view is where they shoot through the armpit in order to see the bottom of the C-spine. And when you do that, you can then say you've got an adequate X-ray. The other thing is that I've often noticed people are asking for swimmer's views without first looking at the normal C-spine X-ray, which you can see here. So a swimmer's view is only asked for when you don't have a good enough view on your normal C-spine. The other things to take note of on the C-spine, you need to know the anatomy. So whereas C3, C4, C5, C6, C7 generally look like normal vertebrae as the rest of the body is, C1 is known as your atlas, all right? So if you want to know what C1 looks like a donut, all right? That's exactly what it looks like, a donut. And then the thing that I always tell people is, what does C2 look like? So that's C2 with the odontoid peg. So you've got to imagine a donut with an erection. All right, so I know it sounds a bit weird, but that's exactly what it looks like. It looks like a donut with an erection. So you've got a ring, and then you've got a ring with an odontoid peg, all right, or with an erection that's sitting up over there. So that's what those two look like. The other thing you've got to take note of in the C-spine is that normally the C-spine is curved. And even when we're looking at this one, you can see this one is absolutely straight. So when you have an absolutely straight C-spine, you've got to start thinking of muscular spasm. Now, this can occur purely in muscular spasm, or it can occur, for example, when there is a fracture. Now, in this particular set of x-rays, I'm not too worried about you guys being able to figure out the diagnosis. We're going to see the diagnosis, and we're going to look at the x-ray and analyze each one at the same time so that you get an idea of what your C-spine should look like. And we're going to get to open mouth views and things like that. And this is just an introduction to C-spines, just so that you get an idea of what the C-spine actually looks like. Okay, so let's have a look at this. So this is called a neural arch fracture. All right, so we've got C1, C2, and we can see a fracture through here. Now, if you can imagine any sort of ring, all right, when you fracture a ring, it never fractures just in one place. You always have a fracture at 2 points. I mean, if you try and break a donut in half, it'll never break at just 1 point. It always breaks at 2 points. So chances are if you've got a fracture here, you've got a fracture on the opposing end as well, all right? So neural arch fractures are not that common, but it is something that you have to look out for. And in this particular X-ray, if we follow the lines, for example, if you see the anterior, middle, and posterior line, there actually isn't much to see. They're actually quite well aligned. The only thing to notice is that there's a loss of normal lordosis or loss of the normal curvature, which tells you that there is spasm. So what happens is when you have any sort of injury to the neck, any sort of fracture, your body puts on its own hard collar, if I can put it that way, and that's your spinal your paraspinal muscles actually go into a spasm in order to keep the C-spine as rigid as possible. So that's your body's own protective mechanism in order to prevent any sort of further injury to that spinal cord. Whenever you see this, don't just assume it's only muscular spasm. There may be fractures that are lurking over there, and you've got to have a good look at it. All right. And in the absence of the straightening, it doesn't mean that there's no fracture as well, but it's just a little tip for you guys. Now, clinically, what should your patient have? Your patient will have generally a neck that is quite stiff and quite rigid, and they're unable to move past 45 degrees. So that's about 45 degrees. Your patient won't be able to move their neck past that. Once you have that issue, and with most patients who have fractures, actually, if you turn their heads just a little bit, try and do any sort of flexion and extension, they immediately resist. This should let you know, of course, that there is some sort of fracture going on, or there's a possibility of a fracture. Then, of course, if there's any sort of neurological fallout and things like that, you have to be aware and be careful. Remember, your C-spine, once it's injured, there's no going back. Now, we are lucky in our hospital settings. Most of our patients come in with, by the MRS, they're already in collars or they're in blocks or something like that. When you're doing your clinical assessment, of course, you are actually rubbing the spinous processes and you're looking forward to any sort of steps and any sort of deformities, swellings, and things like that. But my advice always is that if there's a possibility, keep that neck as rigid as possible or as stabilized as possible until you see the X-rays. Don't try and move the neck. But sometimes you do get some odd things. I always remember a patient that I had. This was actually a few years ago. She was actually helping somebody get something off, off a high shelf. So ironically, she put her boyfriend on her neck. Now, this guy here, as far as I'm concerned, is a complete idiot because it should have been the other way around. She should have gone on his neck. But in any case, for whatever reason, they decided that she's going to be at the bottom and he's going to go on the neck. And after that, she experienced severe pain. And she came in, she had one set of x-rays done at night, and I think they said NAD, they sent her home, and the mode of injury was quite strange, so they assumed that it was just some sort of neck, spasm and things. And she came back 2 days later, and we redid the x-ray, and we actually found a neural arch fracture. So it was just sheer compression because at some point he actually climbed on top of her head and sat on top of her head, and then there was a compression fracture. So always beware when your patient complains of pain, and you can get some odd presentation sometimes as well. Okay, so this is your odontoid peg that you are looking at over here. So your odontoid peg slips into the front of the ring of C1. So that's how and now it's quite a complex anatomy if you have to look at the cruciate ligaments and things like that. If you have a chance, go and look at it. But your odontoid peg and your atlas, or your atlas and your axis, all right? C1 is your atlas, C2 is your axis. They are the ones that are responsible for your head remaining as still or as positioned as what it is, all right? So that your skull is able to rotate and things like that. So especially with fractures around here, rotation becomes a major issue. As you go further down, flexion and extension become more of an issue. Now, the odontoid peg fractures are also classified in a particular manner. They're graded from, in terms of stability and instability. That's not our job in the emergency department. Our job in the emergency department is to identify. So on a lateral, this is what you will see. All right, now in this particular case, if you follow the anterior line, you can immediately see the step that occurs. And you can see it's not a continuous line. And even if you go to the middle line, you can see that there's a step. Now, remember, the middle line is actually the most important one because this is the one that tells you whether there's going to be a spinal injury or not. Okay, your anterior line is then next important, and your posterior line is I wouldn't say the least important, but third in terms of priority. So you've got to make sure that the middle line is always in alignment, or there's a straight line. Now, in this case, you can see there's a step off, and you have the anterior line as well. And then when you follow this, that's when you can see the fracture. Now, how do we get a better look at C1 and C2? The way that we do that is that we actually do an open mouth view. All right. So an open mouth view is exactly what it is, straight through, so that you can see C1 and so that you can see C2. Okay. Now, this is the open mouth view of this odontoid peg fracture. Now, this is actually an unstable one that would require referral to a spinal unit. All right. Now, what are the things that you need to note on an open mouth view? Number one, of course, you have to note that there's an odontoid peg. You have to note if there's any fractures that you can see. And we're going to see this just now in terms of a burst fracture, what it looks like. But the other thing that you look at is the alignment of C1 and C2 here specifically. All right. So in other words, the two lateral borders should be in straight line as well. There should also be no difference in terms of the spacing on either side of C1 or C2. So these are the things that you look at in an open mouth view. So don't just ask for an open mouth view as a regular thing. If you suspect C1 and C2 are fractured, that's when you ask for an open mouth view, because that's all that you can see on an open mouth view. Right? In this particular one, we can see if we follow the cortex of C2, we can actually see where the odontoid peg is fractured, and that's the fracture line running through. So these types of patients will often be sent to a spinal unit. Okay, so this is another open mouth view, and in this particular one, we're looking. Let me move my head a little bit. Sorry, we're looking at what they call a Jefferson fracture or a burst fracture of C1. Right now, the way that you make it out, number one, if you follow the contours, you can see there might even be a possibility of a fracture around the odontoid peg, but I think it's more of an artifact. But look at what happens when you follow C1. And you see that the lateral borders are actually now not in alignment. So the reason for that happening is if you have, let's imagine that this is our C1, right? So as soon as there's a fracture, the fracture occurs in two places and the body tends to separate. So that's why you get this overhang, and that's why C1 is separated from C2. Now, the same thing can happen in C2, where you can have a fracture of the body, although generally the odontoid peg, because they will not allow it, but it does happen that C2 can actually be further away. So C1, in other words, could be there, and then you have C2 that's actually out of alignment. So this is what happens when you have neural arch fractures or body fractures. And burst fractures can occur at C2, but they're much more common in C1, right? So it's a burst fracture, it's a compression fracture that actually splits C1 and causes it to move apart. But you can have just a normal fracture along the body of C1 as well. I hope that makes sense. Because I've seen people misread these before. So it's not much to look at. It's the alignment, it is the odontoid peg, and just to follow the cortex as well. And with that alignment, in this one, you can see it quite obvious, all right? So if you follow the arrow over there, you can actually see how C1 has moved away because there is a fracture. So your next step would be CT scan, referral to an orthopedic surgeon who would then take it further, all right? And in fact, in the emergency department, majority of the time, when you see any sort of C-spine injury, your first step is immobilize that thing with a hard collar, or at least with head blocks. Don't take your patient off the head blocks. And make sure you get a CT scan as quickly as possible. All right. So here we're looking at facet dislocations. All right. So when you look, let's go to the next slide because I actually want to show you how the vertebrae look. So your vertebrae have two facets on either side. All right. So these facets basically interlock into one another. All right. So this is showing you a unilateral facet dislocation. So what happens with the unilateral facet dislocation? If we can imagine the two vertebrae sitting on top of one another with their facets interlocked. When you have, let's imagine my thumb is one of the facets and that facet now is dislocated, but the other one, my small finger, is intact. And what happens is you have sort of like a rotational motion that happens. But because the other one is in place, it actually decreases the amount that the spine can move. And once you have a bilateral, so in other words, both of them are dislocated, there's nothing to keep that spine from moving. All right, and that's actually, well, both are quite dangerous because you can sever the spinal cord. Now let's go back to what these look like. So first of all, let's make sure our X-ray is fine. We're going to concentrate on this one first. So we're looking at C1, C2, C3, C4, C5, C6, C7. So it's an adequate X-ray. Then we're going to have a look, and in this one also we can see there's a loss of lordosis. Then we're going to go through the posterior line, I mean the middle line. So let's follow that middle line. And as we go down, we can immediately see the step here. All right, so that's where you can see the step. And then we follow the anterior line, and again, we can see that step over there. And when we follow the posterior line, the main thing that we notice is the discrepancy in terms of the distance between the spinous processes. So this is a unilateral facet dislocation. The reason that we say that is that the percentage that the body has moved compared to the lower body is less than, is about 25%. Once it's above 25%, then you start saying that it's a bilateral. But the important thing is not, in the emergency department, is not to classify it, but to recognize it. In both cases, our management doesn't change. Immobilize the neck, CT spine, orthopedics, and there's a high probability of two things. Number one, neurological fallout, and number two, neurogenic shock. So neurogenic shock occurs because of the severing of the spinal cord. The blood vessels are unable to contract. So you have this systemic vasodilation that leads to a drop in BP. So these patients, how do you manage them? You manage them with fluids, of course, to try and increase the volume. Adrenaline, if that's all that you have, you run adrenaline, but the best one is phenylephrine, right? No adrenaline, because it causes vasoconstriction. Okay? But not everybody has access to it. If you do have access to it, it's quite an easy thing. You take 1 M, you mix it in 200 mils of fluid, and you run that at 10 mils per hour. If you only have adrenaline, 4 M's in 200 mils at 10 mils per hour, which is a standard adrenaline dosage, and then you can take it further from there. It's just that adrenaline doesn't have as much of a vasoconstrictive effect. It does, but not to as great an effect as noradrenaline. It rather has an inotropic and conotropic effect on the heart. So you're making your heart pump harder in order to keep those BPs up. Okay, now let's look at the other one. So here we're going to count again. So we've got C1, C2, C3, C4, C5, C6, C7, but we can't see the top of T1. So this is one where you would also ask for a swimmer's view so that you could see the top of T1. All right. Now, in this case, you may not, because this patient, as you can see, is probably going to be in need of urgent CT and orthopedic management. But just to give you an example of where you would ask for a swimmer's view. So in this case, we look at the posterior line, and you can see this huge step off. And even on the anterior line, there's a huge step off that occurs. And when you follow the posterior line, you can also see it just deviating out. So this is a bilateral facet dislocation because of the amount of movement. So it's more than 50% of the vertebral body that's moved across. So that's why we say it's bilateral. Now, in our case, these patients are at high risk for neurological deficit, neurodeficit paralysis, and of course, what do you call it, neurogenic shock. So that's why you've got to manage these patients quite aggressively. Okay. So you place them in a hard collar, C-Spine, CT, you can include a brain CT, and orthopedic management as soon as possible. Okay, so we've already covered what the facets look like. Oh, the other thing I wanted to mention, yeah, you'll notice that with the unilateral facet dislocation, your spinous processes also are no longer in alignment. So that's something you can see on an AP if you want to look at that as well. All right. So now we're going to look at some wedge fractures. So wedge fractures also occur with any sort of compression force, teardrop fractures that we've got on this side. So let's have a look at the X-ray again. So let's go through our system. So we've got C1, C2, C3, C4, C5, C6, and here we can see C7 and T1 are not clear. So we would ask for the swimmer's view as well. Now in this particular case, sorry, I'm not sure what happened over there. Just sort of went into like a small, just get it as a big screen again. Right, let me just try that one more time. Not 100% sure what happened. I think it just closed the thing up. Ah, there we go. Let me close this up. Okay, so it's giving me two. I'm not sure why there's two of me now. But anyway, my apologies for that. Okay, not sure what happened over there exactly. But let's get back to where we were. All right, so I suppose we were, right. Right, there we go. Okay, back again. All right, so let's have a look and see. So the one thing we can note, we can also see the loss of lordosis on both of these. As we follow the posterior line here, you can actually see the movement of here. So there is a slight step off on the posterior line. And when we follow the anterior line, we can see where the fracture is occurring. So these fractures, as you can see, it's a buckled anterior cortex. There's lots of height of the anterior vertebral body. So these patients, again, you're going to immobilize the C-spine, get a CT as soon as possible. Okay, and here we have another one where we see C1, C2, C3, C4, C5, C6, C7. It's another candidate for a swimmer's view. But the main thing to notice over here, in fact, we can see there's almost a reversal of the curvature of the spine. And when we follow the posterior line, you can start to see that there's a bit of a step off that's occurring at two levels. And when you follow the anterior line, you can actually notice it again. So this tells you that there's quite a bit of force that's been applied to the neck, and that's where the fracture has actually occurred. There's a widening of the facet joint, what they call fanning of the spinous processes as well. But the most important thing is in these patients, CT, immobilize. That's all that we're going to keep on repeating over and over again. So this is a hangman's fracture. Now, Hangman's fracture, Hangman's dislocation, is actually a dislocation of C2 from C3. All right. So this happens with hyperextension of the neck. If you can imagine your occiput touching the back of your shoulder, touching onto your shoulder blades. Now, this is exactly what happens. All right. Now, this was in the old days. We used to see this quite often before we had headrests in our cars. So this was the reason that headrests were actually developed in your car, to prevent these types of fractures and dislocations taking place. Now, of course, they can occur with hangings as well. That's what they call hangman fractures. What used to happen before was that you would get an anterior movement, and when the head snapped back, it would actually snap back that much, and you get C2 dislocating from the C3. So it's exactly what it says over here. Hyperextension of the neck transmits the force through the C2 pedicles, and this results in an oblique fracture originating anterior to the inferior facet of C2, extending superior posteriorly, and exactly what it says over there. All right. So this anterior ligament that normally sits over here becomes unstable, okay, and it's forced through the pedicles. Now, if you were to follow exactly what you're saying, C1, C2, C3, C4, C5, C6, C7, so this is an adequate X-ray. And if you were to follow the posterior line, you can immediately see, and of course with the anterior line, you can immediately see what's going on over there. So these are all those typical types of C-spine fractures that we see. Now, these are all graded as well. So the thing is, the lovely part about the emergency department is that we don't need to know all of that. Because we need to know so much about so many topics, we leave the grading up to the orthopods. Okay, so these are the things that we need to know. So this is a spinous process fracture. Now, in this particular case, let's follow our system. So we've got C1, C2, C3, C4, C5, C6. So this is definitely an inadequate X-ray. We'd have to ask for a swimmer's view. If we were to follow the posterior line, we don't see much. If we were to follow the anterior line, again, there's not much to see, but we can see this little osteophyte query fracture or compression here on C5. Right. And when we come to the posterior line, that's when we actually notice the spinous process fractures that are occurring here. So it takes quite a bit of force to fracture the spine. And it takes quite a bit of force to fracture the spinous processes in and of themselves. Okay, so this is the type of patient also that may well present with severe pain. As you can see, there's a loss of lordosis. These patients also deserve a CT of that spine. They deserve to have their spine immobilized and for an orthopod to have a look. Now, the reason for the CT is that we may have fractures that are underlying here that we can't see, linear fractures. It depends on the type of movement, the type of force that's applied. So generally with these, you have a posterior force that's applied or a lateral force that's applied. And this is what actually fractures the spinous processes. So, these are the types of things that we have to be careful of. So this is more or less the end of this particular round. This is just a joke to finish off. Now, if you guys have any questions, we are going to continue with C-spines next week again. This was just to give you an introduction on how to read these X-rays. So you remember that, look at the 3 lines, look at each vertebra, make sure that you can see up to C7 and T1, and make sure that you follow those lines. Make sure that you look at everything and ask for a swimmer's view when necessary and ask for an open mouth when necessary as well. So I hope everybody enjoys it, and we're going to have 3 lectures in total about C-spine. So even though I didn't cover everything today, don't get worried. We are going to be covering a lot over the next 2 weeks as well. Okay, so I hope you guys enjoyed it, and yeah, we are going to end there. Okay, thanks. Bye.